things. The four important things are the airway assessment, history, and investigations, and last is fasting status. Based upon this, you will certify the patient that he is fit to undergo anesthesia or not. So pre-anesthetic checkup is a vital step in anesthesia. Now guys, in this pre-anesthetic checkup, I told you these four things, but the most important thing in the PAC or pre-anesthetic checkup is the airway assessment. So what do you do in the airway assessment, guys? What do you do in the airway assessment? We'll start with the airway assessment. Now imagine there are two patients. Patient A and patient B both came to you for pre-anesthetic checkup. Both you are doing airway assessment and you told patient A to open his mouth. While he is opening his mouth, you are seeing this kind of mouth opening which looks like a restricted one. And patient B, his mouth opening is a bit good. So what do you think, guys? Which patient can be easily intubated? Patient A or patient B? Obviously patient B. Why? Because you are able to see all the structures clearly. That means you are having adequate space to do a laryngoscopy and intubate the patient. So this is a case of easy airway. This is a case of difficult airway. Okay? So to predict the easiness or difficulty of the airway, there are many classifications given, guys. One of the classification that we commonly follow is called as Mallampatti classification. Mallampatti classification. But before going to Mallampatti classification, in the airway assessment, when the patient comes to you for a PAC, you tell him to open his mouth and lift his chin. As he is opening his mouth, you will look for two things. The first thing is what, guys? The first thing is Mallampatti classification, which I have discussed with you. Mallampatti classification. And the second thing is what? Inter-incisor distance, IID. So when you tell the patient to open his mouth, you will look for these two things. Second is you tell the patient to lift his chin. As the patient is lifting his chin, you look for two things. What two things, guys? One is the thyromental distance, other is the sternomental distance. So what is the normal thyromental distance? Normal thyromental distance is nothing but 6.5 centimeters. And the normal sternomental distance is double the thyromental, that is more than 12.5 centimeters. Any distance of less than 12.5 or less than 6.5, it is considered as a short neck or the difficult airway. Okay, so first remember, guys, as we are telling the patient to open his mouth, we are looking for the most important classification, which is called as Mallampatti classification. It is very simple, guys. Mallampatti's classification is nothing but you tell the patient to open his mouth and you look at the structures. If the structures are easily visible, that means you can easily put the laryngoscope. Okay, there are four classes: class 1, class 2, class 3 and class 4. Now guys, remember, in class 1, as we tell the patient to open his mouth, you are able to see all the structures in the mouth clearly. That is nothing but what? Pillars, tonsillar pillars, you are able to see. Uvula, you are able to see. Hard palate, you are able to see. Soft palate, you are able to see. Everything you are able to see clearly. That is Mallampatti class 1. Okay, so when we are discussing about Mallampatti classification, Mallampatti class 1 means what? You are able to see it is denoted by a mnemonic push. Push is nothing but what, guys? You are able to see the tonsillar pillars. You are able to see the uvula, you are able to see the soft palate, and you are able to see the hard palate. Hard palate. That is called as what? Mallampatti class 1. Okay, Mallampatti class 2. When do you say class 2? Remember, guys, class 1 is denoted by push, P-U-S-H. Class 2 is denoted by U-S-H. USH. Now remember, here also you will see partial tonsillar pillars could be seen. Partially you can see tonsillar pillars in class 2, but you will see uvula. But remember, the tip is not visible. Tip not visible. Okay. Next, soft palate is seen and hard palate is seen. Hard palate is seen. That is class 2. Then coming to Mallampatti class 3. When do you call Mallampatti class 3? Remember, PU is not seen. Only S and H is seen. S is nothing but soft palate and H is nothing but hard palate is seen over here. Okay. Uvula, only base is seen over here. Base of uvula could be seen over here in class 3. Class 4 means what, guys? Class 4 means only H is visible. That is nothing but heart palate visible. Now guys, remember, heart palate visible means what? That means the patient is having easy or difficult airway. As we are progressing, always we need to remember as we are progressing in the Mallampati classification, the airway gets difficult. So Mallampati class 3 and class 4 are difficult airway. Why? Because you are not able to see the structures clearly and you cannot put the laryngoscope. That's clear. Okay. Then there is one more class, guys. Mallampati class 2. Nothing but push. यानी कि all class 1 structures plus when the patient is opening his mouth, you might also see tip of epiglottis. Tip of epiglottis visible. Tip of epiglottis visible. Okay, in this picture, it is basically which classification, guys? This looks like Mallampati class 2. Okay, so push plus tip of epiglottis visible is class 0. So that is Mallampati classification, guys. Now, next, so that was the airway assessment. Next, we are going for what? This question. Patient is posted for hemorrhoidectomy under spinal anesthesia. The anesthetist did not take proper history and posted now the patient on the table, and on table the patient is having bleeding from the surgical site. Hemorrhoidectomy patient is bleeding on the surgical site, and later it was found that the patient is on clopidogrel. So basically, guys, remember, now you will know the importance of PAC. Remember, in the PAC, most important step is airway assessment. But apart from airway assessment, you also take the history and other things also. So if PAC of this patient was done properly, he would have come to know that this patient is taking clopidogrel. Clopidogrel means what? It ideally needs to be stopped. Now patient is posted for hemorrhoidectomy, which is an elective surgery. In all elective surgery, PAC is mandatory. In elective surgery, if you do PAC, you will come to know patient is having this problem, patient is having that problem. So guys, remember, patient was posted for hemorrhoidectomy and now he is bleeding. So in the PAC, I told you the next important step is what? You look for the comorbidities and investigations. Now, guys, remember, for comorbidities, basically the disease is not the problem, the medications are the problem. For the medications, what we need to remember, some medications can be continued before surgery, some has to be stopped before surgery. I used to remember all active agents are always approved. All active agents include what, guys? It is antihypertensive. All antihypertensives can be continued before surgery except of ACE inhibitors and ARBs. ACE inhibitors and ARBs. Next is what, guys? Anti-anginal medications. Yes, we need to continue anti-anginal medications. Next is what? Anti-lipidemic medications. Anti-lipidemic or anti-dyslipidemic medications. Atorvastatin, rosuvastatin can be continued. Next is what, guys? Anti-epileptic can be continued. Next is anti-thyroid medications can be continued before surgery. These are the medications that can be continued, and there are some medications which needs to be stopped before surgery. I used to remember that before surgery, patient clothes are usually not allowed. So patient should remember, my clothes are not allowed before surgery. My clothes are stopped. Yani the medications are also starting with my clothes. This my clothes you need to remember. M stands for what? Monoamine oxidase inhibitors. They have to be stopped. How many weeks prior surgery? 3 to 4 weeks prior surgery. If the patient is taking patient is suffering with depression and he's taking monoamine oxidase inhibitor, that needs to be stopped. Why? Because if you use monoamine oxidase inhibitor and post the patient for surgery, usually from the anesthesia point of view, we use pethidine more commonly for the patient when the patient is having shivering during anesthesia or for pain relief purpose. If you give pethidine and patient is on monoamine oxidase inhibitor, then what will happen? Severe sympathetic reaction will occur. That's why 3 to 4 weeks before surgery, monoamine oxidase inhibitor has to be stopped. Next, clopidogrel has to be stopped at least 8 days prior surgery. Next, lithium has to be stopped at least 24 to 48 hours prior surgery. Oral hypoglycemic drugs has to be stopped on the day of surgery. T stands for tricyclic antidepressants has to be stopped 3 weeks prior surgery. H stands for heparin needs to be stopped 6 hours prior surgery, and S stands for smoking, which needs to be stopped ideally 2 to 6 weeks prior surgery. That is very, very important, but it is usually when we say the patient for elective surgery, we say the patient not to smoke. If the patient is smoker and all, then we have to take a precaution. Usually if you tell the patient not to smoke for 6 weeks, he won't listen. He will just stop 1 or 2 days before surgery only. So if the patient is telling you that doctor, I have stopped smoking, you don't believe him. Okay, what you do is, if he's posted for surgery, you think what could happen, bronchospasm could happen. So what you can do is post him for surgery, give some hydrocort, give him some nebulization, so that you can prevent all those complications. Okay, so those are the things that need to be continued, and those are the things which need to be stopped. Now guys, remember, we are going to the last part of the PAC, which is basically, now in the PAC you will be telling the patient, please be in a fasting state. If you don't fast, then what could be the problem, guys? If the person doesn't fast, the problem would be what? Problem would be risk of aspiration. So guys, remember, fasting guidelines in adults. In adults, how many hours of fasting? If he's on solid food, 8 hours of fasting. Semi-solid food, 6 hours of fasting. Liquid food or liquids, ठीक है, without यानी कि liquid यानी कि juices without pulp and all, whether it is adult or child, 2 hours of fasting. 2 hours of fasting. But if the child is on mother's milk, guys, remember, we are talking about now child is on water, 2 hours of fasting. If he is on mother's milk, 4 hours of fasting. If he is on formula feed, 6 hours of fasting. Fasting is mandatory for all elective surgeries. Okay, emergency means you have to take the patient for surgery, and you have to go for anesthesia with the help of RSI, rapid sequence induction. But for elective, it is very much mandatory. Okay, now guys, next. So after the fasting, now we have to certify the patient that you are fit to undergo anesthesia. What is the certificate given? Guys, that is called as ASA certification or ASA classification. Now, in ASA certification, there are 6 classes. Class 1, when do you call ASA class 1? When a patient is coming to you, you have done the PAC and he is having no systemic illness. Yani कि patient free from systemic illness. No systemic illness means class 1. Class 2 means what? Patient is having a mild to moderate systemic illness. Yani कि he is diabetic. Patient is posted for hernia surgery. He is diabetic, but which is under control. That is patient having mild to moderate systemic illness. He might be he might be a social smoker or social alcoholic. That is ASA class 2. Class 3 means what? Patient having moderate to severe illness. He is obese. He is having a moderately reduced ejection fraction. Okay, or he is having diabetes which is not under control. ठीक है, यानी कि uncontrolled diabetes and moderate reduction in the EF and all. Those patient comes under ASA class 3. ASA class 4. When do you call ASA class 4? When the patient is coming for like some surgery like hernia or hydrocele surgery, but he is telling you, the doctor, 2 months back I had an MI. So that MI that he had 2 months back will pose a threat to his life during this surgery. So any patient who is having a systemic illness which is life threatening, that comes under ASA class 4. Example, recent MI or recent stroke. Okay, then there is class 5. Class 5 means what? He is a moribund patient without surgery. Chances of survival are nearly less only. So that is a class 5 patient, a moribund patient. Okay, example of moribund patient means ruptured abdominal aorta. Okay, class 6 means what? Brain dead patient. Brain dead patient yani कि now the patient is not posted for himself. He is not benefiting himself. He will be benefiting others. That is basically you are harvesting an organ from him. That is brain dead. Now guys, remember, in short, ASA classification gives you what? It's a certification that the patient is fit to undergo anesthesia or not. Remember guys, class 1 means what? I am healthy without systemic illness. Class 2 means what? I have a mild systemic illness. Class 3 means what? I have a severe systemic illness. Okay? I have a severe systemic illness. Class 4 means what? I am at risk of dying. Why? Because I am having a life-threatening illness. That is class 4. Class 5 means what? I am about to die. Class 5 means basically without surgery, the patient might die. And class 6 means what? I am dead. So that is basically the ASA classification, guys. ASA classification. Now coming to what? Now coming to the next topic, which is called as local anesthetics. Now guys, local anesthetics